Hello, my name is Tracy Caroline Bank, and on behalf of my co-authors, I am pleased to present our work entitled The 30-Minute Rule for Expedited Delivery, Fact or Fiction. The 30-minute rule in question refers to a commonly held belief that the best outcomes occur when the time from decision to first incision for an expedited cesarean delivery is fewer than 30 minutes. In our piece, we review the background and historical studies that led to this belief, the current standards and national guidelines, and the data that is currently available on neonatal and maternal outcomes associated with urgent delivery. We recommend standardization of terms used to designate delivery urgency and encourage reconsideration of the 30-minute rule. In 1982, a 15-minute decision-to-incision time was first put forth as a standard of care in the setting of animal studies that indicated an association between greater than 15 minutes of hypoxia and widespread neurologic injury. In 1987, a national hospital survey revealed that 88% of the 538 hospitals surveyed had the self-reported ability to prepare for a cesarean delivery within 30 minutes. Additional timeframes were not reported. In 1988, in an effort to balance feasibility with outcomes, 30 minutes was adopted as the decision-to-incision time for an urgent cesarean delivery. After several studies we'll review later, and associated calls for reconsideration of the 30-minute standard, these guidelines were changed in 2017. The 2017 Guidelines for Perinatal Care, put forth by the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists, acknowledge that the scientific evidence for a 30-minute rule is lacking, but that hospitals should maintain the ability to initiate a cesarean within 30 minutes of decision. Despite this, many hospitals and courtrooms across the country have continued to use 30 minutes as the standard of care, with legal and quality metric implications. It is important to note, in review of neonatal outcomes, that many adverse outcomes are related to factors throughout a pregnancy, and thus long-term health is only sometimes related to intrapartum decisions. It is also important to note that there is likely a difference between reversible and irreversible causes of fetal compromise. There have been numerous studies of urgent, emergency, and stat cesarean deliveries that show no difference in APGAR scores, NICU admission, acidosis, seizures, and death rates at 30, 75, 120, or even 180-minute cutoffs. However, the extent and reversibility of fetal compromise, along with the resuscitative strategies implemented during these timeframes, is rarely included. In studies of irreversible stressors, such as cord occlusion, cord prolapse, or complete abruption, there does seem, however, to be some linkage between time and injury. This table summarizes key studies involving neonatal outcomes and their findings. It also emphasizes the heterogeneity of studies and terminology used, with bradycardia to delivery times, decision-to-incision times, and decision-to-delivery times, along with urgent, emergency, and stat terms used to encompass a wide range of clinical scenarios. When it comes to maternal outcomes, there have been several studies that have found increased risks associated with faster delivery times, including increased risk of bladder injury, bowel injury, wound infection, transfusion, and hematomas. General anesthesia is also commonly used to assist with speed of delivery, and this has been associated with increased risk of hemorrhage and adverse maternal mental health outcomes. It is worth noting, however, that the indication for requirement of an emergency delivery likely plays a role in maternal mental health as well. Here is a summary of the studies involving maternal outcomes, most of which find either no difference between different timeframes or an increase in maternal complications with a shorter timeframe. We would like to propose a standardization of terminology for classification of delivery urgency. Class 1 is a cesarean delivery requested to the need for rapid delivery due to an immediate threat to the life of the mother or fetus. Class 2 is a cesarean delivery requested due to concern for the fetus or mother, the timing of which may be delayed to allow for additional measures such as further intrauterine resuscitation, the arrival of additional personnel, cross-matching of blood if need is anticipated, or administration of regional anesthetic. Class 3 is a cesarean delivery requested in the intrapartum period for which delivery is recommended, but there is no immediate perceived threat to the mother or fetus. Class 4 is a cesarean delivery that could be scheduled to best accommodate patient and delivery team. We recommend that the 30-minute rule be abandoned as a standard of care. We propose that there is insufficient evidence to support a decision to incision or a decision to delivery interval. Class 1 deliveries should be performed as expeditiously as possible, with attention to maternal safety. Class 2 cases should first be managed conservatively with intrauterine resuscitation, while arrangements for delivery are started in case conservative management is unsuccessful. Within 15 minutes, fetal compromise should be identified and addressed. This includes with strategies of maternal repositioning, correction of maternal hypotension, acidemia, or hypoxia, discontinuation of uterine stimulants, or administration of terbutaline if tachysystole is suspected to be contributing. And if fetal recovery is suspected to be unlikely, efforts to move toward delivery should start within this time. We urge future research in the following areas: antepartum and intrapartum predictors of both short-term and long-term neonatal outcomes, approaches for teaching and practicing evidence-based intrauterine resuscitation strategies, development of additional intrauterine resuscitation modalities, and strategies for improving maternal safety in emergent deliveries, including support for maternal mental health after traumatic birth experiences or adverse outcomes. Thank you very much for your interest and attention.